practice. Okay, so there's brilliant talks on today ranging from relationships and intimacy, navigating at work, living well with MS, and fitness in MS. So if you're tweeting today or anything, can you use the hashtag MSExplored? That'd be great, thanks. So before I start, I just want to know more about you basically. So there's a few questions. As you see, there's little tabs on your seats. And we'll just go through a few questions, okay? Just to get to know a bit more about everyone. Okay, so tell us about yourself. Where have you travelled from today? So you can select A, B, C, D. Perfect, keep going. Super, so Dublin. I'm from Kerry. Brilliant, next question. I'm not great at technology. How did you hear about this meeting? So if you can select. Okay. Okay. How did you attend last year's meeting? So you want to select. It's not working? Oh, it's open. Oh, good. You voting? Super, so it's your first meeting, like myself, so I hope you enjoyed today. Which age bracket do you fall into? So mostly 25 to 35. Will you be posting on social media? Hashtag MSExplored. No. All right then. Right. So I hope you really enjoy it and get a lot from it. If you have any questions, you can come up to myself, or there's members from MS Ireland here today. So you have Ava down the back, you have Aoife, and Tom. Where's Tom? Tom's at the bar. So I hope you enjoy it and ask loads of questions, all right? So without further ado, our first speaker is Dr. Maria Go on. Living well with MS, she'll be speaking about.
Thanks very much. So it's lovely to see everyone here today. I might met some of you. I'm currently working in St. Vincent's Hospital. I'm in the MS clinic there. I've been there now for a couple of years. It's one of the biggest MS clinics in the country. And at the moment I'm working on research into multiple sclerosis as well as working in a clinical capacity. And I'm going to talk today, really what I see in clinic a lot of the time is that people don't have as much understanding of MS as I think that they do, that as I expect them to. And I think it's really important in order to live well with it, to understand it as well as possible. So a lot of today is just about going into what MS is like, what to expect, some of the recent research into it, and then some of the practical aspects about treatment, and we're going to go into pregnancy a little bit as well. So some disclaimers. So it's a very variable condition, and I think that's what I see a lot of the time, and what people find very frustrating is, I was mentioning earlier on today, somebody disclosed to their work colleagues that they had a diagnosis of multiple sclerosis, and the answer was, oh, my friend is that, and he does a lot of marathons, and that is one extreme, but that is not everyone's experience, The other extreme is you get a diagnosis and you imagine in your head what we used to see a lot in the old days, the neighbour down the road who was in a wheelchair from a young age because they had MS. So neither of the two extremes really reflect reality. It's a very variable condition, and while everyone here has MS, your experience of the condition will be a little bit different to the person sitting beside you. We see a lot of people in our clinics, the vast majority of whom who have relapsing or remitting multiple sclerosis are working in a lot of different capacities, and also do electives abroad. They travel overseas, they do higher education, they leave, they retrain, they switch careers, they do all kinds of things that everyone else does in society without a huge amount of difficulty. And I think that's important to remember. Your life doesn't have to stop, and it often, but not always, doesn't have to change dramatically from what you expected it was going to be. So this is just what we're going to go into a little bit today. So to start off again, how many people in Ireland roughly do you think have MS? Sorry. We'll go back and do it again. Sorry. So I'm going to start again. I've closed the polling and I can't seem to reopen it. Yeah. I don't think it'll reopen again. Good? Yeah. Great. So we've got quite a few responses now. I'll close the polling in a couple of minutes, or a couple of seconds. And, okay. So let's see. Yeah, so between 8 and 10,000 people in Ireland have multiple sclerosis. So it's a relatively rare condition. About 1 in 400 people will get MS, but there's still a lot of people living well in the country with this diagnosis. So what is it? It's a chronic condition. So once you have it, people do sometimes say, will there be a cure? And I think that's unlikely. But I think it's going to be a very manageable condition for most people into the future. It involves inflammation, but there's another part to it, the neurodegeneration, where sometimes the nerve cells and parts of the brain and spinal cord can break down a little bit. And that's usually more prominent later on in the condition, and when people talk about progression, that's usually driving a lot of the progression when people get to the progressive stage of the condition. When people say it involves the central nervous system, what does that mean? It means it involves the brain and the spinal cord. Okay, so that's what it affects. It affects the white matter, which is the part of the brain really where all the connections are. So the connections come from outside of the brain and they travel down through the substance of the brain, the white matter, into the spinal cord and further out than that. It does also affect the grey matter, we know that, but it's predominantly a white matter disease. So the connections between the different parts of the brain, between the brain and spinal cord, are affected. Women get it more than men. I think we can see that reflected today as well. A lot of people get it when they're young, but we're diagnosing more and more older people. It would be not uncommon for us to diagnose people in their 60s, less common in their 70s. People always say, thought that was a younger person's disease, but we are seeing it more in older people. A group that are often a little bit left behind are children and young people who can get it at a very young age. It can be a little bit aggressive when they're younger. And a lot of the treatments that we have available haven't, for obvious reasons, been tested in children, so it can be a bit more difficult to find the right medication for them. It also has a big impact on children and teenagers, and quite a few people here might have been diagnosed in their teens, and it's such a busy, important time in your life. You're in school, you're doing your leaving cert, you're starting college, and that can be very disruptive. It's such a key point in your life. We know that there is an impact in that the further you are from the equator, the more likely you are to have multiple sclerosis. But if you're from an equatorial country, so if you're from, for example, parts of Africa, and you move to Ireland at a young age, your risk changes to that of the Irish population. Okay, we see a lot of people from Eastern Europe, Russia, also diagnosed with multiple sclerosis, and New Zealand and parts of Australia seem to have quite a lot of multiple sclerosis as well. Why do we get it? And we get asked this question in clinic a lot of the time, and despite all the research and understanding we have, we still don't fully understand. There are environmental factors. We know that there's a relationship with vitamin D, which is why most people will be advised to start on vitamin D. We know that most people who've had multiple sclerosis had glandular fever, or mono as it's known as, when they were teenagers. The EBV virus seems to be implicated in some ways. We don't fully understand why that is. You can have that as a teenager often, or as a young adult, but sometimes it can be asymptomatic and you might know that you have it And we know that smoking, some environmental factors definitely play a part as well. The genetic side, and again, when people are diagnosed, they're wondering, what will this mean for my children? So there definitely is a genetic association in that we see a lot of people with a parent, brother or sister, an aunt, an uncle or a cousin with MS. If your parent is MS, your risk is higher than the general population, but it's still low. It's about 1 in 70, 1 in 80. Okay, so it's still very low that you're going to develop it, but it's higher. In identical twins, it's about 1 in 5. So it's a genetic component, but it's not everything. It doesn't count for everything. So what happens? So if you imagine your nerves like an electrical conduction cable, and the myelin is the kind of conduction coating part on the outside of that cable, that's what's damaged. So it slows down the transmission of signals from our brain and our spinal cord to our arms and our legs. Diagnosing multiple sclerosis, every so often the international groups get together and come up with criteria about how do we diagnose it. And sometimes it can be a little bit more difficult than you might imagine. The most recent diagnostic criteria were developed in 2017, and really what they're allowing us to do is make a firm diagnosis of multiple sclerosis at an earlier stage. So a lot of people would have had the experience where they have had one clinical attack or one clinical event, and they might have had a scan and had a couple of dots, and your doctor might have said, well, it looks a bit like it, but we're not saying that it is for definite yet. So now we can say for definite a little bit quicker. Part of that is that lumbar puncture, looking for that protein in the spinal fluid, has become more important in making diagnosis. So for almost everyone that's being diagnosing now, we're recommending a lumbar puncture. So what does your scan look like? Kind of hands up, how many people have seen their scans? So probably about 2/3, but still a good portion of people have never seen their scans. And that might be because you don't want to, or maybe you haven't thought to ask, but it can be kind of helpful to visualize it, and I often show people their scans just so they get a picture of what I'm seeing, and this literal picture of what's happening in your brain and your spinal cord. So if we look at the image here on the top left, that's a sideways view through the brain, and if you see the kind of white fluffy spots in the middle of that scan, that's the lesions that we talk about in relation to multiple sclerosis. In the second scan, that's as if I'm looking down on somebody's head and slicing it in half. The big white area in the middle, that's just fluid in the middle of the brain that we all have. But if you look around the outside of that, you'll see little fluffy dots and spots, and that's what we call the lesions. And they're around the ventricles, so we call them periventricular lesions. So if you've seen your report, you might see mention of these periventricular lesions. The reason this is all important is where they are is important. As we age, everyone gets dots and spots in our brains. Some get more than others. If you smoke, you get more. If you have migraine, you get more. And in MS, they're in a particular pattern in particular locations. The second picture here is your spinal cord. So the spinal cord is the grey kind of column surrounded by the spinal fluid going right down the middle here. And it's more difficult to see the lesions in the spinal cord. It's just our MRI scans aren't as good at picking it up. But you can see little patches of white in the middle of the spinal cord, and that's spinal cord lesions. So looking at the subtypes of multiple sclerosis, the vast majority of people, about 85%, have relapsing remitting multiple sclerosis. So if you have relapsing remitting multiple sclerosis for long enough, the majority of people will turn into progressive MS. But for the majority of people, that will be a very long time into the future. Okay, and we'll come into some of the recent data in that. I do see people in clinic who are in their 60s, 70s, even their 80s, who've had MS for 40, 50 years, who are still walking. They might need a bit more assistance now that they're older, but they're still doing very, very well. So just to be clear, it is a progressive condition, but what we do is push that time to progression as far away into the future as we possibly can. And that is, for most people, quite possible now. The more difficult type of MS to deal with is, and the one that we haven't had a lot of success with at the moment, or so far, is primary progressive MS. And with primary progressive MS, your disability starts off, you've had a little bit of trouble walking, you might drag your leg a tiny bit after you've been for a long walk. And instead of having a relapse that you recover from, it gets a little bit worse all the time. And up until recently, there hasn't been really any good disease-modifying treatments for primary progressive MS, but within the next couple of years, we're expecting to see some changes there. Having a look at just this medical language, I don't want to spend time on something that people know already. So, do you want me to go through some of these terms? Yeah or no? Yeah? Okay. There's a few, enough nods. Go ahead anyway. So, just because these are some terms you might hear in clinic or you might hear discussed about you, what do they mean? Transverse myelitis is inflammation on the spinal cord at a particular level. Okay, that can be some people's experience of a first clinical relapse. A spot in the spinal cord gets inflamed and you have symptoms. The symptoms you might have is numbness and weakness, sometimes urinary problems as well. That can be probably about 20 to 30% is their first presentation, and for most people that recovers after time. Optic neuritis is probably the majority of people's first presentation. It's inflammation on the optic nerve that results in pain when you're moving the eye, loss of colour vision first of all, so colours look all kind of washed out, and sometimes blurring of vision as well. You might go to the eye near first of all, like there's a problem with my eye, and then you've got an optic neuritis, then you might have a scan and get referred on. CSF is the cerebrospinal fluid, so that's what we take out when we're doing the lumbar puncture. If anyone's had one, anyone's seen it, it's kind of like, it looks like water, it's just a little bit thicker than that, it's very clear fluid. And what we're looking for in the CSF is this protein, oligoclonal bands, and we take a blood sample as well. We want to see, is it in the CSF and not in the blood? And if it's in your brain and spinal cord fluid and not in your blood, that's highly suggestive of MS. Relapse rate, so all the studies that are done, or most of the studies that have been done to date on MS drugs, what they've looked at is relapse rate, so how many relapses you have in a given year. Most people don't have any relapses in a given year, which is why there's a lot of problems with some of the clinical trial, but that's what the studies have been based on so far. Your EDSS is your disability score, so how are you doing? Is there any change in that over time? So we check that in clinic, and again, a lot of the clinical trials have been used on. One of the key kind of markers in that is when you get to about 6.5, and that's when you go from having a little bit of trouble walking to needing a stick to walk, and that's kind of a marker of a change in your condition, that you're really starting to struggle. Progressive MS usually is when your EDSS is about 4 to 6, so gradually over the course of a few years you used to be able to walk 2 miles, then you could do 1.5 miles, then you could do a mile, then you could do half a mile. And that's where we look at, are things changing to progressive? Again, it's not something you need to worry about early on. It's a much later down the line issue for most people. A lot of people in clinic will have done a 25-foot walk test. We get you to stand, walk down the corridor, time you, stop, turn around, do it again. And that's just, it's a very brief little test, but it does show a change over time. If you used to be able to do it in 4 seconds and now it takes you 6 seconds, you might feel fine, but that suggests to us it's a bit of a change. I have a bit of a bugbear about terms like mild MS, and a lot of people come in and say, oh, I've just got mild MS. So in my mind, mild MS is a retrospective diagnosis. So if you're sitting here now and you've got MS, we won't truly know if you've got mild MS for another 10, 15 or 20 years. Okay? So it's particularly the case if you're newly diagnosed. There are some predictors of how you're going to do, but nobody's going to know for a few years how your MS is going to change. And I think sometimes people can think, I've got mild MS, therefore I don't need to take treatment. I've got mild MS, why do I need to go on to a stronger drug? And I think that's where sometimes the language that we use confuses things for the patients that we see. Okay, and I think it's important to clarify that. I've had a lot of conversations with people who say, but my MS is mild. I say, no, you are well, and I expect you to stay well, but in order for you to stay well, we need to act appropriately, okay? Highly active MS is a small cohort of people, and it means people who have, I think it's about 3 relapses within the first year, year and a half of having their condition. And usually that only is probably about 10 or 15% of people with MS. If that's you, you need to be in a very strong, good treatment early in your condition. And that's important. NEDA is one of the new buzzwords over the last couple of years. It means no evidence of disease activity. So what does that mean practically? It means you feel fine, you haven't had any relapses, you're walking and everything else is just the same as it was the last time we saw you, and you've got no new lesions on your scan. And the newer drug trials are targeting this when they're looking at people that they're treating with a drug. So life expectancy is almost normal. It's almost the same as everyone else. Hard to predict. There's more MS out there, but the impression overall is that it's becoming a milder disease. Okay? So what's happening is that they did a couple of studies, and so this one from British Columbia in 2006. So the time from diagnosis of MS to needing to use a stick in a lot of people who were mostly untreated was 28 years. Okay, so that's pretty good. In a Swedish study that was done a couple of years ago, it was 30 years. So we kind of think that maybe we're diagnosing MS a little bit earlier. We're also probably managing it a little bit better. But there was a lot of focus previously on people who were more highly active, even though that is a smaller group of people with MS. So another sign that things are getting a little bit better from an MS point of view. So what age is it that half people with MS might be having some trouble walking, might need to use a stick? So in 1990, the age was 55, and in 2010, that age was 63. And 2010, we didn't have a lot of disease-modifying therapies available. That has changed a lot in the last few years. So we're pushing out the time where you're going to have problems, or the age where you're going to have problems further and further down the line. That's what we're targeting. In one US study, they followed up a large group of people with MS, and half of them had no change in their disability over 10 years. Okay? And that included a cohort of people with primary progressive MS as well. Just a few lifestyle factors I'm going to mention briefly. I'm not going to really talk about exercise, and BMI I'll just mention briefly, but smoking is an important one. You're actually more likely to get MS if you smoke. A few large studies have shown that. And if you have, some people say, for example, have this thing called radiologically isolated syndrome, which is you have a migraine, you're getting bad headaches, you get an MRI scan, and there's a few dots and spots that were a bit unexpected have appeared on it. We call that, if you've a normal clinical exam and never had an MS relapse, that's called radiologically isolated syndrome. And we follow people with RIS for up to 5 years at least every year to see if their scans are changing. People who smoke are more likely to convert to a definite diagnosis of multiple sclerosis. There's also some evidence that you go quicker from relapsing, remitting to progressive MS, and more importantly, and really rheumatology have led the way with this, and things like rheumatoid arthritis and the immune therapies they're using for that. Smoking seems to reduce how well all these therapies work. Okay, so that's why smoking is kind of important there. Another question I get in clinic a lot is, what is an MS relapse? So it's new neurological symptoms lasting more than 24 hours that often are due to new visual symptoms, balance problems, numbness or weakness. What I would say is the first thing we always ask people is, do you have an infection? Are you sick in any other way? Because that can cause symptoms that you aren't even aware of to kind of come out if your body is weakened in any other way, okay? And that's probably the commonest things that we see. There's a wide range of issues which I'm actually not going to go into here because there's a couple of things I want to talk about in a little bit of detail. But what's likely to make your symptoms worse? Illness, so treat a urinary tract infection promptly. Get the flu vaccine, it's that time of the year. Don't shake hands with me later or you might catch my cold. Fatigue, stress and heat can all make things worse. So fatigue is one of the commonest symptoms in multiple sclerosis. It's really difficult to treat. One of the first things to look at though is your sleep. Are you sleeping well? And a lot of people I discuss fatigue with, they're actually not sleeping well, and it might be because they're getting up 2 or 3 times a night to go to the toilet. they're having insomnia, they're having difficulty getting to sleep, they're waking early in the morning, they might be having some mood problems in relation to that, they're having some pain in one of their legs, they're getting spasms that are stopping them to get to sleep. So the biggest thing first of all is to optimise your sleep. Look at diet and exercise because it can make a difference. There aren't really good medical options. Some people are on modafinil. We put people on it quite a lot, and I think it benefits probably about 1 in 5 people that we put on it, perhaps even less than that. Lifestyle is really important, just to focus your energy where you want it to go. So decide, okay, I don't have that much energy, I'm very fatigued at the moment. What is most important to me to do at the moment, and focus on that. One of the big things that we're looking at in MS now is we kind of know a lot about the physical disability, but it's become clear there's a lot of issues with cognition for some people. And that's because just what changes often is your information processing. So it just takes a little bit longer to process things that you were once really quick at processing. Now for most people, particularly in early stage, that has no meaningful impact on your life. But if you're doing something very high level at work, for example, if you're doing a lot of accounting, you might notice that work that used to take you 10 minutes now takes you 15. Just give yourself the extra time to do that. That'll be important. Look at medications that you're taking, in case some of them have an impact on cognition. A big study that was published lately, people who were taking cannabis for their MS, that was having a huge impact on their cognition, and that was clearly seen when they were taken off it. Fatigue has a big impact on cognition, and mood. So if you're low for any reason, if you're depressed, if you're down, if you're anxious, that really is a big knock-on effect in your cognition. And what we've noticed in clinic is people who say, oh, my memory's terrible, and then we go and test it, the two things often don't match up very well at all. Okay, so what often you subjectively feel about your memory isn't actually what's true in reality. And sometimes people who say, oh, no, I'm grand, they're the people who are actually struggling a little bit more, you know. Optimizing brain health is kind of one of the buzzwords nowadays, but it is important to engage your brain, to use your brain, learn new things as much as you can, do things that challenge you a little bit more. Mood is a huge issue, and it's part of the condition. So any condition that affects your brain will have an impact on your mood. It's just biologically going to happen. And some of the things that we see are anxiety and depression, and then an adjustment disorder, to adjusting to having a chronic condition in the first place can take a lot out of you and can take some time to get used to. So there's been a couple of big studies done as well. This is really important for lifelong living well. You've already got one problem, you don't really want to get another. So do everything you can to avoid having diabetes, high blood pressure, and minimise your chance of heart disease and stroke. Treat infections promptly, as we've already seen. For managing your MS, there's a lot of different people involved at different points in the condition. Thank you very much. And how much they're involved depends on where you are. So there might be a time you need better physiotherapy, that's the most important thing. Another time you've got changes in your scan, then the radiologist reading the scan is the most important person. Maybe you're having some challenges with work and adjusting to that, then it's your occupational therapist. A lot of different people involved and of different importance at different times. Okay. So these are some of the treatment goals. We've kind of talked about the lifestyle considerations. So we've got another question. How many disease-modifying therapies are available for MS? So it is actually more than 12 at the moment that are available, so there's a lot of different medication options out there. So I'm just going to throw up this slide. Some of them are the injectable therapies that have been around since the mid-90s, the interferons, Copaxone, glutaric acetate, then the oral medications that have come out more recently, Tecfidera, Gilenya, and Aubagio, Tysabri, which has been around now for almost 15 years, Lemtranimab, included Ocrevus, rituximab, stem cell therapy, and ocrelizumab isn't available yet, but we're expecting it to be available in the next month or two. Rituximab we're using off license at the moment, so that means it's not an official MS drug, but we're still using it. It's very similar to ocrelizumab. And there's another medication coming out shortly that's along the lines of fingolimod, but will be for progressive MS, which is siponimod. Okay. Daclizumab was available briefly, but unfortunately it was taken off the market about 2 years ago now because of some pretty serious side effects that had to be taken away from. So this is just a slide showing how long we've had treatments and how long we've been, what's been available. So we've only had treatments for just over 20 years for multiple sclerosis, and over the last 10 years there has been a massive change in the number of drugs available. Aside from that, some people will be on symptomatic treatments. So if you're having sexual dysfunction problems, you might be on a medication like Viagra. If you're having fatigue problems, we might try you with modafinil. If you're having a lot of pain, you might be in a pain medications. So if you're not sure, always have a discussion with your doctor or nurse, about the difference between the disease-modifying treatments and the symptomatic treatments. And I think one of the important symptomatic treatments I haven't mentioned there is Vampira, which can be very good for walking speed. So there's a lot of debate in multiple sclerosis at the moment about how should we treat it. 2 different approaches that can be taken. One of them is you hit it really hard with a very high efficacy drug very early in the condition, or you start with maybe the slightly less effective drugs and gradually build up over time. Okay? And we don't know yet which one of these approaches is more effective, but there was a good study out there about last year from a Welsh group showing that a group of their patients who were treated with a more highly active drug, who were more disabled at the beginning when they were treated, were doing better at 5 years than people who started with one of the lower efficacy drugs, were less disabled and gradually changed over time. So there is an argument to use something more highly effective, but why don't we want to use that? Because the more highly effective medications carry a degree of risk, and that can be a risk that's challenging for the patient, it can be a risk that's challenging for the doctor. It's a very individual decision and something you need to think about. So if you're picking a treatment, have a think about what you want to do. Does your doctor have a preference? Sometimes people now are like, oh, it should be all the patient's decision, but that's not. I think that's not entirely fair either. It's largely your decision, but you need to be guided by our experience and advice as well. I'm not going to run through all the treatments now, but we can come back to that later. How will you be monitored? You'll be monitored with an MRI scan. Most people that'll be annually. Clinic visit, which will be either 6 months or annually. Usually if you're stable, that will be annually. And then you'll have monitoring based on your medication. So I think when you're coming to any treatment, what you need to think about yourself, and have a think about this before you come to making a treatment decision or a treatment switch. What is your perception of risk? And for some people that's very high. They're like, I'd take anything so long as it would help. Some people it's a lot lower. What we find across the board is that people who are more disabled, who have more problems with movement, want to take on more risk. And people who are well don't want to take on as much risk, even though that's the group that can probably be benefited most from medication. So what do you want to do with your life? Are you going to be going travelling? Are there sports and hobbies that you want to do? Is coming in every month for an infusion going to be difficult? How are you taking tablets? Are you going to be able to take a tablet every day? How do you feel about injecting? And are you considering pregnancy? So just maybe a quick show of hands. How many people have discussed pregnancy with their doctor? Do you put your hand up, Lily? It's about probably a third. Okay, maybe half. So what's really important, and there's been a lot of new data about this lately, is ensure that you're stable before you start to conceive. So if you have a scan with new lesions on it, it's not the time to stop medication and to try to conceive, because you're more likely to have difficulty. So you should have no new lesions in your scan and no recent relapses. There's pretty good pregnancy guidelines published in the UK lately. Overall, there's no evidence that MS has an impact on fertility. It used to be that evidence suggested that it doesn't lead to increased relapses or disability progression, but that's not true for everyone. And there is definitely a cohort of people that I have seen who do worse after pregnancy. It's usually people who are more highly active to start with. When you're pregnant, the chance of having a relapse goes down in the first 6 months and is almost impossible in the last trimester. But then as soon as you have the baby, things kind of bounce back up again, and there's a much higher risk of relapse postpartum. There's a lot to think about, and there's been some, and that's the individual therapies and the advice there, but I'll just run through things quite quickly. You can now use Copaxone right up until conception and during pregnancy. It's licensed during pregnancy, depending on your circumstances. You can now use the interferons, so the other injections, right up to conception and during pregnancy. Gilenya, definitely don't use it during pregnancy and stop it 2 months prior to trying to conceive. Tecfidera is the same. If you're a bit more active, Tysabri is probably the best option for you. You can use it to conception. I was at a recent talk at the excerpts, the big MS meeting, where 2 neurologists from the continent who have a lot of experience in pregnancy are using it in their patients up to 30 weeks gestation and then stopping it. It can cause some minor blood abnormalities in the baby if it's used after that. Mavenclad and alemtuzumab can be used after a certain period of time. It's usually 4 to 6 months, and breastfeeding is another complicated issue. So I'm just going to throw up this slide about some of the issues that people have. But in summary, it's a very variable clinical course. It is becoming a milder disease. If you're diagnosed now, your prognosis is good for most people. We would expect you to do well in the medium to long term. In the long term, for most people, but not everyone. And the difficulty is you can't predict at the beginning. There's certain markers. If you have a lot of spinal cord lesions at the beginning, you should definitely get onto a highly effective treatment early. Young men tend to do a little bit worse, even though women are more commonly diagnosed. And early treatment is essential. So it used to be 10 years ago even, people would be diagnosed, it'd be like, oh, let's wait and see. We'll wait until you have another relapse. We'll wait until you have something new on the scan. The scan isn't picking up everything that's going on. So you could be having inflammatory activity in your brain that we are not seeing on your scan. So I'd strongly encourage everyone to be on a treatment as early as possible, because if you are, that's the group who does better in the longer term. And feel free to discuss things with your doctor. Sometimes you might agree exactly on what your option wants to be at the moment, but keep the conversation open, okay? And come to an understanding of both sides. And you can always seek another opinion if you want to as well. And I don't know if we have any time for questions now, maybe after. Yeah, so we'll do questions at the end of something. Yeah. And you can pop your questions in the question card, which is very handily just there. Okay, so thank you very much for the opportunity to talk to you this morning.
That was a super talk. Thank you so much. Loads of information there. Like mentioned there, if you have any questions or anything, jot them down in your cards, in your packs, and you'll have a chance anyway to ask at the end. Okay, so next speaker is Sinead Brady, and she's speaking about navigating at work. Thanks, Sinead.
I think, can everybody hear me now? Yeah, great. I'm just going to stay on the floor, if that's all right. My name is Sinead, and I am a psychologist who specialises in the workplace. And I suppose there's a mild obsession on my behalf with the idea of careers, of work life, and the integration between work and life for everybody that goes into the workplace on a day-to-day basis. And I suppose work is a really important thing for everybody, and I want to talk to you about navigating your career and your work life on your terms via your own definition of success. So in your little packs, I'm going to ask you to do some writing if that's okay. So in your little packs, you've got one of these notebooks, and that's I wanted to give you that notebook because I firmly believe in, and there's a really strong link between writing and actually helping to draw your thoughts together. So we're going to do a little bit of writing this morning, and I'm open to like bits of feedback as we're going through that. Obviously I've got a set time and I have to get through some stuff, but I'm really open to having some kind of two-way conversation as we go through the process this morning. So just to give you a little bit of background about myself, I have my own business. It's called Workstyle, and that's in the middle of some change at the moment. I'm a mum to 3 young girls, so I have a 7-month-old, a 5-year-old and a 6-year-old. Yeah, they're 5 and 6, yeah. And I operate my own business from my house in Cavan, where I live. I came from Ulster this morning. I was the one person that if I had one of those, I would have been pressing the button. I travel up and down to Dublin twice a week to my office in Bagot Street, and then it depends on where I am across the course of the day or across the course of a week or a month. But what I want to talk to you about, I suppose, is the notion that work and career is changing. Not just now, but it is changing on an ongoing basis. And what I mean by that is how we work, why we work, and where we work is fundamentally different from how we worked, where we worked, and why we worked 10 or 15 years ago. And if a really simple way of thinking about that is if you just think about your phone. I mean, if I'm looking at the faces, and I was also the person that had to tick the box between 35 to 50, and that's a painful box to tick actually, when you have to do it for the first time. But the majority of you are not in that bracket, so you may or may not remember a time when your phone wasn't connected to the internet, or when you had to actually do your you didn't do social media because there was no social media. So the world is very, very different, and our phone has now changed from something that was attached to a location at home in the wall, and you couldn't move from that location, to something that you carry with you, and you can actually run a business from that phone anywhere in the world at any point, at any time. So we have went through this really big journey, if you just take the phone in terms of careers. And not only have we went through a journey, the types of jobs and the types of careers that are available to us because of that have fundamentally changed. So just 10 years ago, it wasn't possible to be an app developer. It wasn't possible to be a social media expert. It wasn't possible to run somebody's social media for them because those jobs weren't there, quite simply. But now we've moved from a job and a career spectrum where you had to be in a location at a particular point in time to being able to carry out your career via your phone from anywhere that you want to in the world. So the world has changed dramatically in how we engage with our careers, the how, the why, and the where that we do our work. And the first thing I'd like you to kind of just think about a little bit this morning is, how do you define success in that new reality? And how do you define success for yourself in that new reality of the world of work? So what do you want from work for you? Why is that what you want from work for you? Are you defining success according to the terms that somebody else has set on success? So are you looking at success based on social media and what you see other people doing? Are you comparing yourself to somebody else? Are you comparing yourself to what looks like success for somebody else? We all get involved in that comparison piece. But really then when you sit back and say, actually, success for me looks like this, you begin to take ownership of what your next steps are for you personally. So for 60 seconds, and I'm going to time you, could you please just write down what success looks like for you in your career and your professional life? 60 seconds. And there's a reason I'm picking 60 seconds. It's not to be quick, but 60 seconds, please. And remember, this is success defined by you, for you. Words, ideas, whatever you can think of. Use my mic in the meantime. There we are, I'm back. So 60 seconds. Anybody willing to share what their definition of success is? I understand that you might not want to, and that's okay. But anybody willing to kind of just say, well, actually, success looks like to me this? Yes. Okay, so there are three really important things. Absolutely. Yeah, fundamentally important. And I think anybody else that's a really honest kind of whole approach to what work looks like or success looks like for you. Anybody else willing to share, or you don't have to? Okay, I'm seeing lots of heads going down and it's like, that's all right. So success might look very like, sorry, what's your first name? Rachel said to you, but it might also be very, very different. So, for example, my definition of success at the moment is being able to pay the mortgage while spending as much time with my children as I possibly can. That's actually my definition of success. Nothing more, nothing less. There's not a particular job attached to it. There's not a particular set of circumstances attached to it. So every decision that I make refers back to that. And for yourself, Rachel, or for anybody, what you've written down in front of you, when you're making decisions about work or about anything really in life, what does that refer back to your definition of success? And you're using your own parameters of success to actually live your life by. That's the first thing. The second thing is you are better at everything that you do than you think you are. So if there's one thing that you can take away from today, take away the statement that you back yourself at work. Back yourself at work. And back yourself in your work. Because 100% I can tell you that you are better at what you do than you think you are. And there's something very simple that you can do on an ongoing basis to remind yourself of how you're doing and what you're doing. So I want you just to write down now, for another 60 seconds, a list of the things that you have achieved in the past 2 years. Everything that you've achieved in the past 2 years. No phoning a friend at this stage. Think about yourself. Into the notes and just words. It doesn't have to be, it can be a brainstorm, it can be words, it can be whatever. But just put loads of things down, whatever you can think of. There's the 60 seconds. And I'll use this when I give you when there's the 60 seconds. So can you just look at what you wrote down? Anybody willing to share some of the achievements in the past 2 years that you would have? Yes. Congratulations, brilliant. Did you enjoy it? Well, are you? Okay, brilliant. Super achievement, and then everything that goes along with that, like the build up to being able to kind of do that kind of distance. What is it, 10 kilometres? 10k, that's a journey, like, so it is. Yeah, brilliant, good stuff. Anybody else willing to share kind of an achievement or something that you have done in the past 10 years that you can say I'm proud of, or the 2 years that you're proud of? Come on, there's more in the room than that. Yes? You've graduated? Amazing. So you finished your degree and you got a scholarship to do a postgrad. Fabulous. Okay? I think your hand go up for that.
Yeah, I got my qualification earlier this year and I started my own business.
Okay, so what did you get your qualification in?
Personal training.
Good stuff. And you started your own business. Amazing achievement. So 2, and everybody again is different in what they've achieved. Anybody else willing to share an achievement? Incredible. Okay. Such an achievement. Brilliant. And do you enjoy swimming? Good. Okay, fantastic. Which is one of the things that it was suggested, that you're kind of keeping the active piece, and brilliant. Okay, anybody else? Come on, there's somebody else. Okay, there's not. So now what I want you to do is to look at your achievement, and can you state a skill that you learned while reaching that achievement? Just pick one of your achievements. Can everybody hear me? My mic keeps going in and out. But pick one skill, and don't worry about the definition of a skill. Just write down something you learned while doing that. Again, I'm back in the timer, 60 seconds. Whatever you can think of. Now really quickly, I just wanted to move from that to writing down a piece of knowledge that you gained about yourself while reaching that achievement. Okay? Everybody okay with what we're doing? Anybody got a question because you might want me to clarify? No? Okay, so off you go again. So something that you learned, a piece of knowledge that you learned about yourself while reaching that achievement, or one of those achievements. To the end of that, can you just think about how you can connect that to a skill that you can bring into the workplace, or something that you can state to an employer that is transferable to the workplace? Does that make sense? So how can you use that in an example in the workplace as building your professionalism? So every Thursday, as you sit watching Netflix, and you know, between the two, like the series is running and one session of Netflix turns into the next, they're episodes, aren't they? Yeah, I'm not very good at all that terminology. But anyway, you know the way it has like it's 30 seconds until your next, so the next time you see that on Netflix or whatever you're binge watching, you're going to pause the television, and that's your cognitive trigger. That is your trigger to go into what's called Tactical Thursday. And every Thursday you are going to spend 3 minutes doing that very exercise. And you are going to constantly remind yourself of the things that you are achieving. You can use the notebook I've given you, or you can go out and buy one that makes you smile when you look at it. And every Thursday you are going to remind yourself of the progress that you are making, the things that you are achieving, and you are going to give yourself the confidence boost that you deserve. And if you find that exercise challenging to do, please do an exercise, go online to via.org. It is a positive psychology tool that helps you to find the skills and find the strengths that you are not recognizing in yourself. via.org, but every Thursday. So let's take the example of the VHI mini marathon. That involved discipline, training, resilience, and it involved a determination that I am going to do it. Bit by bit, week by week, you built up your skill set so that you could do it. And the knowledge that you learned about yourself is that when you set your mind to something, you can do it, you enjoyed it, and you will do it again.
And it helped me learn to cook, how I need to stop myself with junk food constantly and cook good things, and then I ended up learning how to cook.
Okay, so this is, and that may be something that you haven't really thought about before today, but then that's something that you can bring into the workplace and you can talk to either your employer or a prospective employer about the skill set that you're building. Your degree and getting a postgrad scholarship. Again, to get through a degree, to get your qualification, and then to be offered to apply for and achieve a place on a scholarship in and of itself is an achievement that you can speak to any employer about. So your communication skills are strong. So you've got all of these skills that are sitting in a place. Then when it's Sarah, isn't it? Susan, sorry, I'm awful with names. But Susan, for example, went and did her personal training, and then she set up her own business. That requires bravery, that requires courage. And bravery and courage often comes before confidence. And I think we search for confidence too quickly, and we forget that actually, if we have got into a pool for the first time, post a diagnosis of having to live with MS as a long-term chronic illness, that you actually are brave and courageous. And they are things that you can bring to a workplace and that are valuable in a workplace. So let's begin to think about what you bring from a cognitive diversity perspective. What are the skills that you have that are different than other people, that help you to see the world through a different lens and actually add value to an organisation? And an organisation or an employer who sees that as value is an employer and an organisation that you want to work for and that actually will respect you for the cognitive diversity that you bring to the organisation. You have this great ability to see the world through a different lens, and we all know what everybody seeing the world through the one lens led to, and we had a recession that the world never seen before. That is a mark of people all the same, doing the same thing, and seeing the world through the same lens. You bring cognitive diversity to the workplace and own that. Back yourself, write it into your story, write it into your narrative, and bring it with you. But to stay well and to make sure that you own and manage your career in this workplace, what are your non-negotiables? And these are a set of promises made to you, by you, for you. Very simple. What do you need physically to be well? What do you need personally? And what do you need professionally from your work? Under different circumstances, but after a diagnosis myself in 2012, I left a permanent pensionable job because the environment and the circumstances that I was working in were impacting my physical health, my personal health, and my professional health. And that was a really difficult decision to make. However, I had to try and back myself, and it was with the Bambi-like confidence that I did. But as you do so, your courage builds and your bravery builds. So state what your non-negotiables are. 9 words, 1 piece of paper. Are you sleeping? Are you eating? Are you moving? And did you spend time with people who make you smile? That should happen every day. Did you sleep? Did you eat? Did you move? Did you spend time with people who make you smile? That's the basic for a good life for anybody. Personally, what do you need from your work? What's your commute time like? Are you okay with that commute time? How much do you need financially to be comfortable, as you said, now, but to prepare for the future? From a spiritual perspective, and spirituality means something different to everybody, what do you need? And really consider these questions. And they come down to about 9 words on one piece of paper. 4 words under your physical non-negotiables, 2 words under your personal non-negotiables, and 2 words under your professional non-negotiables. Your professional non-negotiables are defined by what are the skills that you are chasing. We work in a cognitive environment, a knowledge-based environment. That is what you are going to work for. Your work is an exchange of your time and your knowledge for a wage. So what are the skills that you are chasing? Do you want to upskill, reskill, or retrain? Every single person in the workforce currently are going to have to spend between 101 days and 12 months of upskilling, reskilling, or retraining to be relevant inside the next 5 years. That's every person. So if you are in that space where you're saying, I'm future-proofing my career and I'm going to upskill currently so that I can step into a more knowledge-based environment, perhaps. How are you going to do that? What are the 2 things you are chasing professionally? You can use edX, FutureLearn for free learning and to taste a course or to taste a professional area for free. edX.org and futurelearn.com. So that you can take a sample and a risk-free sample of how you're going to future-proof your career. edX.org and futurelearn.com. And they have everything on there, from courses in, like I saw a course in sustainable fashion, which I thought was really interesting, right the whole way through, and they're for free. So you can do them for 6 weeks. There's an investment of your time, but you upskill, you reskill, and you retrain through them. And it can be a really good way for saying, here I am now, but I want to go to there. This is what I'm going to do, and this is how I'm going to do it. And it's you sitting in a position of control, owning. And if you do that, even if you log on to edX or FutureLearn, make sure that on your Tactical Thursday, as you're sitting, watching Netflix, and you're hearing my voice going, God, you're a woman, and the break, do it on a Thursday night. Give yourself your 60 seconds or your 3 minutes that we went through and just go, I logged on to edX this week. I've decided that it's going to be between these 2 courses and this is what I'm going to do. Or I got up and I went out and I did this. But make sure that you're constantly reminding yourself of your ability to move forward and be confident in yourself as you do so. And the last thing I would say to you and appeal to you to do is, will you please, and I say this to everybody, figure out who's in your safety network. And that's something that was alluded to very, who's in your safety network? Who are the people that you turn to at different times when you need different things? So when you're having that day where you're feeling down and you're feeling that you need a boost, who's the person on speed dial on your phone for that conversation? When you're having a day that you're feeling down and it's probably a little bit of a, we all have them, pity party, who do you ring that gives you the kick in the bum to say, come on now, up and at it? When you're feeling exhausted and tired, who do you ring to say, will you come and sit with me? Who are those people in your safety network? When you're fighting an infection and you need to talk to your doctor or your nurse, who do you ring? Or who do you listen to when they say, now is time for you to take a break? Who is that person that you listen to? And who are you saying to, please be that person for me? So name your safety network, say who they are, tell them who they are, and then be okay with being in their safety network and them being in your safety network. It's a two-way conversation. So please back yourself. You have a wealth of skills and knowledge to bring to whatever career it is that you choose to do. Allow nobody, give nobody permission to take that away from you. And I heard a really difficult story this morning from Susan around somebody who lives with MS and her job wasn't there for her. And that is scandalous and illegal, what happened to her. However, I would also say that if that's an employer's mindset, that is their mindset. Do not take ownership of that mindset, and do not allow them to take your ability and your brilliance away from you because of their challenging mindset. They have an issue, it is not your issue. And I would say ultimately that in many ways, while it is an ugly experience and it is an illegal experience, that person is somebody you don't actually want to work for in the first place. Back yourself, encourage yourself, and give yourself that 60 seconds a week to step in to owning yourself. Be tactical every Thursday when Coronation Street comes. Is Coronation Street even on? I don't know, I don't watch Coronation Street. Netflix, whatever it is, just find that time to sit and write. Writing helps you to connect dots and helps you to think about things in a different way. So please do. If you've got questions, I will take them. I don't know if I've gone outside of my time, I probably have. I will take questions, there's no problem. My handle on social is @Sinead Brady. It was Workstyle, but this change is coming. It will be Workstyle again, but in a different platform. And I wish you every success. Define success for yourself. Figure out your non-negotiables. Have a tactical Thursday with yourself. Back yourself. And be the best version of yourself you can be. And the very best of luck to you all. Oh, I didn't do the questions. Sorry, I got carried away. So, would you mind? That's a disclaimer. Is that me? Do you enjoy your work? Oh no, there. Do you enjoy your work? Yes, no, sometimes. Would you mind answering? Sorry. 34. I know how many of you are answering. 35, 37, 38. Okay. How many people have we in the room, I wonder? Is that okay? 38? Okay, so yes. That's way above average for any room. Genuinely way above average for any room to have 55% of the people that did anybody not get to answer that I didn't give you enough time? No? Okay. Next one. Are you concerned about the impact of living with MS and what that will have on your future work life? It's a true or false answer. Like, you know, are you concerned, yes or no? Which is a really, I know that's a really, that's a hard question. And it's a very binary one, but something I think that's important at the same time to get some kind of a feel on. Yeah, again, what I would expect. And I think in the current workplace and work environment that we live in, I do genuinely think that the impact will be significantly decreased, particularly where you are looking. And the one thing I should say to you is, look for employers that focus on a work-only results-only work environment. It's called ROWE. So what they're looking for is your engagement with the role, your ability to do the job, and it's not about the amount of time that you spend on site or in the location. It is based on your impact and your productivity. And it's not about being there for 40 hours a week or 35 hours a week. It's actually about getting your work done. So, results-only work environment. Have you chosen to tell your employer that you live with MS? There's 4 of you that aren't answering this one. Oh no. I can see how many people are answering and not. So, yeah, you have, and some of you haven't. And that's a very personal thing. And please be aware that discrimination on any grounds is unacceptable. It's just simply unacceptable. And people do need to be called out on it. That doesn't mean it has to be you, but it is unacceptable. And I think when people begin to realise that this is unacceptable behaviour and it's not acceptable to talk in this manner, the more that we stand up to that cowardice and bullying, the better life will be, if not for us, but for those that are looking up to us from the generation beneath. Do you feel comfortable talking with your employer and colleagues about living with MS? I suppose that's directly related to one of the other questions. Do they know that you're living with MS? Are they hard questions to answer, or questions you've thought about before, or? Okay. Okay. So yes, no, and sometimes. Yeah, okay. Okay. So, yes, this is the last question. Do you think more media coverage of people living with MS would help? Positive media coverage would help to draw out those biases and to stop people from being, I suppose, biased, yeah. Okay. This one is invoking a reaction. Yes. And I should say that my friend has been recently diagnosed, one of my closest friends, my bridesmaid, was recently diagnosed and is currently living through a very new diagnosis of MS. And I get help and support on my social media because it's challenging to do everything. And the lady that supports me on that lives with MS. So this is a really important place for me to be today, and I'd like to say thank you for your time and for your kindness, because there were smiles as I was talking, and the best of luck with everything.
Wow, that was a super talk. I'm sure you all agree. Thanks so much for that. Thank you. All motivated. Do you have the clicker? Sorry. So on. Okay, so our next talker, speaker, I'm sure this will be very interesting as well. So that's Sarah Sproul. She's going to speak about relationships and intimacy.
Actually forgot one important thing, which I will grab now. I am really excited about the quiz component of this, because this is probably the closest I'm ever going to get to participate in some sort of Eurovision voting sort of system. As you can tell, I have an Australian accent. I'm from there originally, but live happily in Ireland for the last almost 20 years. Okay, so that is a euphemism up there. Relationships and intimacy. I'm going to be talking about sex, sexuality, okay? So let's just get straight to the core of it. Disclaimer. Let's do the questions first. So this one is, do you want to be having sex at this point in your life? And be really clear, there is no right answer. No is perfectly good. Yes is perfectly good. Not really knowing, actually, I don't know. Maybe it depends on the quality of the sex, whether I want it or not, right? So give me an answer there. I've had 38 responses, so. Woo! I got a good audience today. Excellent. And a few people there may be quite right, because you never know the quality of it. Okay, the next question is, we got on to the next one? Click right. If you are having sex, because not everyone is, and that's perfectly fine. Do you enjoy the sex you are having? And again, there is no right answer. We're just collecting information. Great, thank you everybody. So, there you go. 2/3 of us are enjoying the sex we're having. And a few people are sometimes enjoying it, some people aren't. And I don't have sex, that's good too. Okay, let's go on. So do you want to learn more about the different ways to do sex? And again, there is no right answer. You might want to learn. You might not want to learn. All good, I don't mind. So yes, no, maybe I want to learn, depending on like how awkward it's going to be, Sarah. I don't know if I want to learn anything else. Just come on, just keep talking. Okay, so thank you everyone. So a lot of people want to learn. That's great, you're in the right place. Some of you don't, that's okay. You can tune out now, go on social, do something on your phone for the next 20 minutes. Some people might want to learn and they're not sure. Okay, so let's talk about sex. I am an occupational therapist and I work in sexuality. So what that means is a lot of my work is to support families with school-age children to have comfortable conversations about sex, relationships, bodies, puberty, how babies are made, all those sort of sensitive, sort of awkward conversations that we might or might not have with our kids or with people in general. So I'm going to do a quick show of hands here. Who, when they were growing up, was surrounded by adults who were actually pretty awkward and embarrassed and maybe didn't even talk about anything to do with body, sex, or puberty or anything like that? Yeah, so I'm in good company. I was raised by 2 missionaries in West Africa. And I went to a school for missionary kids. And one of the subjects we studied was Bible, right? So I have a special skill. I can recite the names of books of the Bible in order. So if you want to come up to me at lunch and ask me to wow you with that, I am completely open to it. Okay, so, and some of you may have a similar experience, that we are surrounded by people who have particular ideas about whether conversations or sex in general is an okay thing to talk about. Before we go any further, I want to get clear on the words that I'm going to be using. So you might have heard already, I've used the word sex, I might have used already the word sexuality. So let's work out what those things are. So sexuality is part of being human, and if you look up there, it's the central part of being human. It's part of our core. It's not necessarily about what we do, but it's everything that makes up our sexuality. It's things like our thoughts, the things we fantasize about, what we value, and the actions that we take on what we value, what we believe to be true, what we desire, what we find sort of exciting, what we would love, and then what we do about that desire. What sex we were born, are we male, are we female, are we something else, maybe intersex? What gender do we ascribe to ourselves? Who do we find attractive? What sort of gender do we find attractive? What do we find erotic? What is pleasurable for us? This is going to be different for everybody, okay? We've got about 38 people sitting in these seats, and all the extra people, that will be, let's say, 45 different sorts of people who enjoy different sorts of things. Reproduction, or whether we can reproduce, whether we choose to reproduce, that impacts our sexuality as well. The body we have, so MS falls into that part. The thinking we have, our spiritual practices, the influences about in the world around us. How is everyone else in our world talking about sex and sexuality? That influences our own sexuality. How much money we have can impact our sexuality. What the politicians are saying about sex, what laws are in our country about sex, what the history was. Okay, yeah, everyone knows about the Irish history to do with sex and all the stuff that went on there. So the religion that we choose to practice, or the religion that the people around us choose to practice, and then the relationships and the roles that we are in. Okay, so do you understand now that your sexuality is made up all different factors? And if you were born to the same parent or parents, you had exactly the same upbringing that you had, but you were transported to a whole other country, like maybe Italy, Australia, France, your sexuality would be impacted because you don't have the same messages coming into you. Does that make sense? Yeah? Great. Okay, so clear, sex is not just, now that's sex educator shorthand for, anyone want to have a guess what PIV stands for? I'm going to tell you and put you out of your misery. Penis in vagina. Sex is absolutely not a penis in a vagina. If there's one thing that you learn from the talk today, that sex is not penis in vagina. It might be for some people, but it's absolutely not for a lot of us, and that's emoji. Just in case you weren't quite sure about PIV. Okay, so let's look at the definition of sex then. If it's not this, what is it? I've got a definition here for you. Being intimate in an erotically arousing way. Right? And in this definition they've said with someone else. But I actually question that. Does there actually have to be someone else to have sex? Here's an example of sex that is not with someone else. In sex educator speak, we call that solo sex. In everyday world, you might call that masturbation or slapping the chop or rubbing one out or, you know, all those different sorts of colloquial ideas about how we describe masturbation. But if we're being really broad about what sex is, the broader we can get about it, the easier time we're going to have of working out what is right for us. What is right for our body, what is right for the things that we desire, what is right for the stage of health we are at. Okay, so rules of comfort today. You can already tell I'm going to go there, right? No holds barred. So your job is to look after yourself. If at the end of this talk I have said something that made you feel bad about yourself, you are not broken. I did not do my job right. I want to be really clear on that right now. If I say something that makes you think, oh, I don't do that, or I never had that, or my body doesn't do that, that just means I was not inclusive enough, and that's rubbish. Okay? So are we clear on that? It won't be about you, it's about me. Let's use the classic breakup line. Okay, so the other thing is, I will be talking about things that maybe people don't normally talk about. And the reason I'm doing that is because I don't want to waste your time. You're here to learn something new, or maybe something that you haven't heard before or haven't thought about before. So if I just do the usual thing about what sex is, we're all going to go out of the door and go, okay, well, I didn't really learn anything. What was the point of that? I don't want that for you, and I definitely don't want to waste my time doing that. So that might mean that sometimes you hear something and it makes you go, that's not right. I disagree fundamentally with Sarah on that. That's not right that people do that. People shouldn't watch that or listen to that or seek that out. And that's okay if you think that. Because we all have different levels of comfort. We all have different things about us that, you know, we like or we don't like. But that doesn't mean that it's not right for the person sitting next to you or for one of the people up at the table here or anyone over there on my left. Okay? So what we're going to do is we're going to use this idea. Don't yuck my yum. Which basically means I might find something really sort of exciting and you don't. And that's okay, both of us are right. You're not going to come up to me and say, oh, that's really disgusting what you like to do or who you like to do it with. And I equally won't say the same to you. Is it a deal? Yeah? Great. Okay, so Snowflake is just there, we're all different. Okay, I'm going to put up, oh, by the way, I will warn you if there's anything that is going to be a bit shocking. Okay, there is a sex toys slide later on. I will warn you. So if you don't want to look at that, you can go like this. Okay, so I've already said that our sexuality is influenced by the messages we have around us. And all of us, and we can't help it, it's not our fault, we have rules in our head that we might not even know is there. So we might have rules in our head about who is allowed to have sex. People who have beards, they're allowed to have sex. Maybe couples are allowed to have sex. Maybe people wearing sunglasses are allowed to have sex. Or maybe we have a rule now that people wearing sunglasses aren't allowed to have sex. Or maybe we have a rule about health status or age. We may think to ourselves, oh, yeah, young people have sex. People in their 20s and 30s have sex. People in their 80s, no, they don't have sex. People that use walking sticks, no. Right? Rubbish. Rubbish. What's some other? We may have a rule in our head that technology and sex do not go together. I would like to challenge that too. We might have a rule in our head, something about boxing gloves. You don't use boxing gloves during sex. Maybe some people do. Yeah, who knows? Okay, so there was actually one other slide there, that picture there that didn't seem to come across, but it was two people in bed, and they had sort of diverse body shapes, and people with diverse body shapes can have sex too. So the rules can be wrong, all right? And if we don't examine what the rules are in our head, then we may be following them, and they might actually be making our life more rubbish, because they may be saying to us, yeah, no, you can't use technology to have good sex. When in the reality of it, our body needs technology to have good sex. So, particularly with MS, that is going to rewrite the rules about sex. People with MS have different things going on in their brain and their nervous system, and I'm going to talk a little bit about some of the impact of MS on our sexual expression. That's another word, so that's like we have our sexuality inside of our, how do we express it? What do we do with it? What are our actions? Okay, so what have we got there? So we've got a banana and an orange. So MS can impact our sexual body, our sexual self. It can impact our genitals, so it may change the way we can have an erection, for example, if we have a penis. Vulvas actually have erections as well. You might not know that, but they do have erectile tissue, and so a vulva's erection can change as well. That sort of puffy, moist sort of sensation a vulva gets, that can be affected by MS. So I'm just putting desert there to show like we might feel a bit dry, and also that we're closed for business if our banana is limp. All right? So some of the other ways that MS can impact our ability to do our sexuality, spasms. Okay, if you're being involved with a partner or partners and it's getting pretty exciting, sometimes you can experience spasm. Every Australian has to have a koala in their PowerPoint presentation. This illustrates fatigue. Yeah, I just really can't be bothered tonight, rather go to sleep. This is talking about our sensations of our skin, how MS will change the sensations of your skin. So something might have felt nice before your diagnosis of MS or before your latest relapse, and now that sensation feels terrible and you don't want to do it anymore. Incontinence, that can really impact your and our feelings of, do we want to be sexual, particularly if we want to be sexual with another person or other people. Incontinence can be something that can overlay a sense of like, oh, I'm not sure how this is going to go, and I'm not really sure that I want to be this vulnerable with someone else, because accidents happen. And then the side effects of any medication you might be on. Now, I'm not going to go into detail about those things, and the reason I'm not is because you are really, really fortunate, because at the back, now they're not in your pack, and the reason they're not in your pack is because Multiple Sclerosis Trust have done a book for a guide for men, sex and MS, and a guide for women, sex and MS, and we didn't know where you were going to sit, right? So if you identify as a man and you would like a guide for men and MS, they're at the back. Women and MS at the back. How can I say this? Don't be afraid to go and get the booklet. Okay, I'm up here and I'm talking about bananas and oranges and penises and whatever else. If you would like a booklet and you just feel a bit too like, oh, I don't want to be seen getting the booklet because now everyone knows I'm going to want to have sex, I'm like, oh my God. Can we just accept that we all in some way want to be a sexual creature, whether that is by doing something or by choosing not to do something. So this booklet is going to be useful wherever you are in the world, okay? Wherever you are in that space. So everyone happy to go and get a booklet at the back? Yeah, great. Okay, so let's move on. How are we going for time? Okay. Okay. Another way MS might impact our ability to do our sexuality would be feelings of maybe depression or anxiety, the way we feel about our body, that our body is broken in some way, that can absolutely impact on whether we are willing to be vulnerable with another person or other people. Okay, so happily, that's not the end, right? Because we have an opportunity to acknowledge that all those things exist or may happen to our body, either that's happening now or in the future, and we can say, okay, that's the way it is, living with MS, what am I going to do now? So let's talk about what's possible. Let's talk about some of the professions that can help us out in our journey through chronic neurological illness. Now, I haven't said this yet, but my partner has Parkinson's disease, and they were diagnosed with Parkinson's disease 3 years ago. We have 3 children, primary school, secondary school age. So I live every day with the impact that a chronic neurological condition can have on a sex life, on a relationship, on a family. So I'm no stranger to this. So when I give you these suggestions, it's not something I've got out of a book. I live this every day. Okay, so we'll start with the boring stuff first, right? Let's look at the list of healthcare professionals. So your neurologist is your first port of call because they are an expert in MS, and they can recommend or refer you on to other people. There is the urologist and the gynecologist there. Sometimes some neurologists will be more likely to ask you about your sex life if you're a man. Maybe because it's more obvious if you're having problems with erections. So if you don't have a penis and you have some sort of genitalia, it may be that you actually need to prompt your neurologist to have this conversation with you. And then it's a bit rubbish. Ideally, our healthcare professionals should be able to give us permission to have these conversations with them by starting it. But, you know, healthcare professionals, we're all only human, okay? So you may need to be the person that starts this conversation in your next consultation. So just be aware of that. A specialist physiotherapist can look at the physical structures to do with your genitals, maybe look at the muscles of your pelvic floor, or all those different structures that can contribute to what an orgasm might feel like. That point there, sexuality educator, OT, that's me. Not all OTs are sexuality educators, and I'll put my hand up right now and say a lot of OTs won't even be comfortable talking about sexuality. So I apologise for that on behalf of my profession. But what I want to acknowledge to you is that this is why it's important that we all give ourselves permission to start these conversations with people who are important to us. That may be your healthcare professional, or that may be your partner, or that may be your casual fling on Tinder, whatever your deal is that you're doing, okay? So I acknowledge it might not be easy to start this conversation, but we benefit from it if we are asking for someone else to talk to these things with us. The last thing is a psychosexual therapist or a sexologist. They can really unpack and help you unpack what the thinking is. You know, those gremlins, those rules that I was talking about before, that may be limiting you in what you can do for yourself. What else can you do if you want to? Okay, self-compassion. Now, interestingly, I think Sinead touched on this idea quite a bit, but I want to just talk about it in the context of our sexual self. Oftentimes in the world, we are told that the beginning stages of anything, of making progress, is to love ourselves. And we might be told that, yeah, if we love ourselves, then we're able to love other people, and that's a good starting point. And I would like to challenge that. Because a lot of us may have trouble loving ourselves, particularly loving our body, particularly if we have some sort of chronic illness. I'm just going to tell a quick story about breasts. So if no one wants to listen to a story about breasts, just put your hands in yours like this. So my partner and I, we had our first child. And when you have a baby, particularly if you've grown it in your own body, your body just changes in like massive, massive ways. And that's what I experienced, and it was really unpleasant and horrible. My bottom was down here, my boobs were down here, my stomach was out here, and it was really confronting. I could not love that body. One day, I'm getting in the shower, I'm feeling okay about myself, and my partner comes in, and I decide, I'm going to give them a flash of my breasts. So we have this glass shower door, and I stand at the shower and I put my breasts against the shower door. I'm thinking, oh yeah, this is a bit sexy. And they go, oh, they're far lower than I thought they would be. In that moment, I could not love myself. I felt ashamed and embarrassed, okay? And you may have a story like that for you, where you put yourself out there a little bit, try and start a little bit of something, and you fall flat on your face. In those moments, self-compassion is where it's at, because we can say to ourselves, this is actually really hard. I am doing a really hard thing here. How I feel about my body just makes me feel incredibly vulnerable. And just accept that even if we had a body that looked like, what's the latest supermodel that everyone thinks is awesome? Anyone give me some? Because I think Cindy Crawford, but that's just showing my age. It's so embarrassing. Anyway, you know what I mean. There are stereotypes that everyone believes, oh yeah, they're allowed to have sex. Everyone wants to have sex with them. But when we don't look like them, it makes it difficult for us. So there is a self-compassion piece in just accepting this is difficult. And that's okay, and I might be struggling, and that's okay. So that's the first thing. I'm going backwards. We might look at, as another way to help ourselves out, why do we have sex? Have you ever thought about why you have sex? You don't need to answer. You may think that the reason you have sex is because of this. Romance. Romance might look like that. Romance might look like this. Romance might look like that. But a lot of our culture and a lot of the movies we watch would absolutely say that the most reasonable and appropriate reason to have sex would be for romance or loving feelings. I might go even far to say that sex with one person that happens on an ongoing basis in the form of some sort of committed relationship is the main accepted reason why we should have sex. But I'm here to give you 42, I think it is, or maybe 46 other reasons why people might have sex. And we're going to go through them really quickly, because if you think that sex should only be happening because you're feeling romance and lovey-lovey, then that's a rule in our head that might not fit the body that we have right now. Okay, let's look at some of these reasons. Excitement. To get an orgasm. Fair enough. To feel comfort. Yeah, okay. To feel wanted. Because someone has asked us to have sex. Yeah, okay. To feel attractive or desired. Yeah. Not wanting to lose a relationship. Valid reason to have sex. Distraction from other things. Oh, work is so bad. Because I haven't had Sinead's talk and I didn't know I was meant to do that Thursday thing. Work is so bad. I'm going to have sex with someone. Preferably someone that wants to have sex with me. And that is the other thing. All these things, it's about consent, right? We're not doing something that we don't want to do, and we're not doing something if we're doing it with someone else who doesn't want to do that back in return. Okay? I'm just going to highlight there are two things in these reasons which may have a consent issue. We might have sex to get money. In some countries that's legal. In Ireland, it is legal to sell sex for money. It's not legal to buy sex for money, so there you go. How's that for a market model? Boredom, we might have sex because we're bored. It could be a form of exercise. So the other person will owe us something in return. Yeah, I'll have sex with you if you pack the dishwasher. We want to feel good in our body because we feel like we're supposed to do it. There might be a consent issue there. If we feel like we have to do it and we don't have the opportunity to say, I really don't want to, there's a consent issue. We might do it out of pity. Oh, the poor thing. I haven't got any for like 3 months. I'm gonna put out. To put your partner in a good mood. Oh yeah, I've got a really big credit card debt at the moment. We are going to have sex 4 nights in a row before I reveal that. To try something new, for a sense of connection with someone else or with ourselves. To get intimacy, to feel powerful because we're angry. That's the reason. To feel normal. To stop the other person pressuring you. there's a consent issue there. If someone is pressuring you to have sex, have a little think about that. Okay, but we're only halfway through. We'll go all these other reasons. To reinforce our feelings of manliness or femininity, to prove something, to try and heal wounds from the past, to reassure another person, to experiment, to reaffirm a relationship, to stop thinking about everything else, to cheer ourselves up because we've got some free time. Oh yeah. As an act of rebellion, I am going to show all those people that don't believe that someone like me can have sex. I'm going to have the best sex life on the planet. To get sex out of the way, oh dear, it's Monday, we haven't had sex since the other Monday, better do it. So we've done our weekly, like put it on the calendar thing. To make someone like us, to let go, to have a feeling of release, to show someone how skillful we are. I like that one. Oh, I learned a new skill. To help you fall asleep, for the afterglow. Some people don't particularly like the sex, but they love the feeling afterwards because you know someone expects it. For stress relief, because it's routine. For fun, to pass the time, out of frustration, to cheer yourself up, and to feel a sense of proficiency like a good performer. Right? So, the reason I read those all out for is because can you see now, there is a wide variety of reasons why we might decide to have sex. And it might have nothing to do with the feeling that we feel romantic or loving towards another person. And they're all valid. We're all different. Whatever reason you have for doing it, as long as it's in the container of consent, completely valid. What else can you do? Now, here comes the sex toy slide. So, sure, I look down, I'm like, oh, sure, we're not going to look at that. It's just like, what's the deal with that, Australian? I'm going to put it on now. Ready? Okay. Here's some of the things we can do. So, MS changes the sensations we have in our body. So let's swap it up then and change the sensations that we give our body. Okay, so some of those are pretty obvious. A lot of people might be familiar with a vibrator. This is a wand vibrator. You can get vibrators in all shapes and sizes. You can get vibrators that stick onto your fingers if you have trouble gripping something. You can get vibrators that you put in your underwear. You can get vibrators that someone else can control. You can get vibrators that someone on the other side of the world can control. I think that's pretty awesome. So if you're in a long-distance relationship with someone in South America, for example, there's weird and amazing, wonderful apps that you need to Google those because I didn't have time to put all those up here. Okay, the purple thing up the top is one form of a dildo. You can get all different sorts of dildos, and for some people, they enjoy putting things inside their body as part of their doing sex. So if you are with someone or yourself and you like something put in your body but there's no penis around that has an erection, these are really good options. And the great thing about dildos is you can get them that they look all different. I put one up here that doesn't look like a penis, but you can get really lifelike ones that look like a penis if you feel comfortable having one like that. Different colours, different shapes. Those black little twirly things over there are anal plugs. So another thing you might be interested in exploring is different sensations in different parts of your body. And I suppose it's pretty mainstream now for sort of people in their 20s and teenagers coming up. Anal sex would be one of sort of their regular practices. But certainly for my generation, I'm in my 40s, it wouldn't have been so regular. So if you're in the same generation as me and you're like, I have never done that, I don't want to do that, only other people do that, that's fine. But if you've got an open mind and you're interested in trying out a different part of your body, then you can try it with something like that. The other thing I put up there, the Tenga egg, is a masturbation sleeve. And it comes in that little egg. And essentially, if you have something to do with the penis, whether it's your own or someone else's, and you're interested in giving that penis sensation with a hand, then you can use a sleeve like this just to change up the feelings that the penis might have. Okay, so, and there are all different sorts of ways you can stimulate a penis. Oh, I didn't say here, another interesting vibrator shape is you can get vibrators that suck on the clitoris, which are really interesting and completely different sensations. So not all vibrators are created equal. And sometimes it's sort of trial and error about which one is going to work for your particular clitoris or other parts of your body, but just to be aware of that. this is not for everyone. Don't go away going, well, Sarah said, we should get a sex toy, so I'm going to get a sex toy. I'm going to go on to something like sexshopper.ie, the Irish sex toy website that Shauna Scott runs. That's an Irish one. There are a few other Irish ones. But this is not for everyone. No pressure. If you want to do it, have a go. If you don't want to do it, don't have a go. It's fine. Okay, now we're going to move on to something too for our mind. This is an app that tells us sexy stories. So for some of us, maybe you don't realize this yet, or maybe you have discovered this for yourself, some of us really like hearing stories about other people doing sexy stuff. It can be incredibly erotic. If you think back into the cave, remember way back, we were all living in a cave. Oftentimes if there was sex happening in the cave, you would hear other people having sex in the cave, right? So it's not unusual for our brain to be interested and maybe a little bit turned on by the sound of other people having sex or talking about sex. And this is one way that we can stimulate our mind as part of our sexual self. So earlier there was a mention of Viagra as one way to look at helping a penis get an erection. And it's only one part of the story, really, because just because we put that drug into our body doesn't mean our mind is at the point where it wants the penis to be erect. So you could take a Viagra and actually not get an erection. You need to sort of plug your brain into it as well. So just be aware of that. So that could look something like this, or it could look something like this. So now I'm getting into the world of sex film, or erotica, or porn. Some people call it porn. So I chose this website for a few reasons. First of all, porn has had a pretty bad rap. Its reputation is a bit, okay, heaps and heaps and heaps of people use porn in their everyday life, but there are some issues with it in the industry. For example, the way that porn performers are treated, whether they are at the right age, whether they are allowed to look after their sexual safety in terms of using condoms or other things to prevent STIs. So a lot of people might have problems with using porn as a way to increase their sexual stimulation. This website is not like that at all. This website is a platform that allows normal everyday people like you and me, if we want to, only if we want to make our own sex films and upload them onto this platform, Make Love Not Porn, and then people have the opportunity to rent the film we made. And we get 50% of the profit. It's like, woohoo, right? So, you may be interested in something like that because for you, visual stimulation is something that you need help to get going. And there's no shame in that. Absolutely no shame. Our culture will say there is shame, but there isn't shame, okay? I had a video where they were talking a little bit about this, and what it basically showed you is there are all different body types on this Make Love Not Porn, all different ages, all different relationship configurations. So what I love about it is its diversity. Books, let's talk books. This book is called The Basics of Sex, isn't it? The Basics. And it's a cartoon book talking about sex, talking about different positions, talking about sexual health, talking about how to talk to other people about sex for ourselves or how to manage sex on our own. And what I love about it is it's diverse, it's funny, it's irreverent. A little bit like me, making jokes, try and keep us all relaxed. We don't need to be serious about this. This website is amazing. OMG Yes. And it is a collection of research done on, I think, over 1,000 women at this point. And this is basically a how to drive a vulva for dummies. Every single way that these 1,000 women have found to arouse their vulva, whether they're doing it on themselves or on someone else. And so, I would be telling this to a group of people who don't have MS in their lives, right? Everyone can benefit from this. If you have either you have a vulva on your body or you're interacting with someone else's. This is the Atlas of Erotic Anatomy and Arousal. It's done by a colleague of mine, Cindy Darnell. She's an Australian sex therapist and sexologist. She now lives in New York. This one and the OMG Yes, they both are a paid thing, so you pay for them, and you get just heaps of videos that teach you things about genitals and how our erotic system works. This is a lovely book. It's called Enjoy Sex. Enjoy Sex, How, When and If You Want to. I particularly love the if. No pressure, right? And it's a kind book, and it's talking about the lies we have in our head that may be holding us back from being able to be the sexual person we want to be, whatever that looks like. And then this book here helps us look at the relationships we're in and challenges the expectations of what we have about those relationships. A lot of us will be thinking, yeah, a relationship, if we're in a relationship with one person or two people or whatever it is, that relationships need to look a particular way. The person I'm in a relationship with needs to fulfill all my needs, my sexual needs, my house cleaning needs, my child rearing needs, my going to the pub needs. And that book breaks it down and says, really? Is that really true? Maybe actually we could look at relationships in a different way, which makes it easier for everyone involved in the relationship. Okay, so I'm finishing now. But I want to finish off with a quote from a sex therapist who I admire, because he has made it his life's work to challenge expectations. And I think really that is the core of the message today, was how could we possibly challenge the expectations we have on ourselves, or the expectations that the culture has on us, or the expectations our partner or partners have on us about what our sexuality looks like or how we do sex. So we're going to finish off with this quote. I'm going to read it to you. When sex doesn't go the way you want or think it should, it's a chance for you to deal with the disappointment of your fantasy, disappointment of your fantasy, and focus on humanity and reality. This is when sex helps us to grow up, or as he likes to say, grow sideways. Thank you very much.
So, us being Irish, probably don't want to ask questions, so the cards are there. If you want to ask any questions, I'm sure you'll be willing to answer anything at the end. Some great take-home points there. Next speaker. Where's the thingamajiggy? Oh, right, okay. Okay, so our next speaker is Professor Susan Coote. She's going to speak about fitness and MS. Thanks.
Great, so those are three really hard acts to follow, so now for something completely different, I think. Welcome, thank you for all for being here. You're on the final straight, we're nearly at lunchtime, don't panic. And probably we should all have a standing break, given that I'm going to be talking about fitness and physical activity and healthy things. So I'm a physiotherapist. I have been working, specialising in MS for about 15 years. I've been at the University of Limerick working in partnership with MS Ireland on a variety of programmes. Ava calls me the Getting the Balance Right lady because that was the very, very first programme we did. Scarily, that was now 14 years ago, so I think I need a new name. So maybe I'll be the Step It Up lady or something different. So just to think about fitness, quick disclaimers. Oh, got to do our questions first. Very quickly, do you feel like you do enough exercise at the moment? How do I do this? So, just press the middle one. I'm going to go with that because there's quite a few people. No, okay, so maybe I can do something to help you out with that. Next one. Do you need to know more about the benefits? Do you think you know that exercise is good for you? is exercise good for MS? That's one of the fundamental questions I'm going to answer. Okay. You would. Good. Good thing I'm here. Yeah, so, and we actually have an exercise guideline for MS. It was published relatively recently. What do you think it says? Which do you think of these might be the closest answer to correct? How much we should do? Slow to answer that one. That's a tough one, isn't it? There's lots of options, first of all, but I think a lot of people aren't aware of that there is an exercise guideline and what might be what we should be aiming for. So, I'm going to keep going with that. So, essentially, doing both strengthening and aerobically, but actually exercising at moderate intensity twice per week, and aerobic and other exercise. So I'm going to explore that later. So I'm just going to spin through these because I'm kind of conscious of time. So I'm going to think about, just in my presentation, I'm going to kind of ask the question, what do you mean by fitness? You know, because I think a lot of us think about fitness, and fitness is not being completely out of breath at the top of the stairs. You're fit, right? But there's a lot of other facets to it. I'm going to think about what the research evidence says, what does the science say about exercise and MS, and I'm going to tell you right now, I like to think I'm not graduated that long, but when I was in college 25 years ago, physiotherapists were taught that people with MS should take it easy. And actually we've done a huge U-turn in a very short period of time research-wise, and I want to share some of the science behind that because I think it's important for you to understand where we're coming from. Importantly, what do people with MS say about exercise? What kind of exercise can you do? How do you get started, and how do you keep going? So first of all, to define fitness, and this is showing you that fitness is more than not getting out of breath, okay? So fitness is about aerobic fitness, it's about muscular fitness or muscular strength, and that strength involves being able to contract your muscles strongly once, but also being able to contract your muscle for a long period of time and over a period of time. So enough, for example, to get to the flight or the third story in a hotel or a house. Flexibility is part of fitness. If you're not flexible enough, it's really hard to be fit. And obviously you need balance to do all of those different things, okay? And I've put the definition there from the American College of Sports Medicine, and really what I want to do is to get to the other end of it. So the opposite of fitness is what we call hypokinetic diseases, and these are the things that happen to you when you sit and do nothing, okay? And that's not good, because there's this new saying that sitting is the new smoking. So sitting is as harmful for us as smoking is. The health conditions, the secondary cardiovascular problems, diabetes, obesity, all of those things that happen when we sit and do nothing are actually really, really bad for us. So any kind of movement is good, and that's what I want you to leave here knowing. Moving is good, all right? Moving a little bit more tomorrow than you did today is good, but fundamentally sitting is not good. And to combat sitting, we have the best medicine, and that is exercise. And there's a whole movement that's not just for people with MS, people with cancer, people with arthritis, people with chronic pain, people who don't have any health conditions at all, people who are obese, who have diabetes. Exercise is a medicine that anybody can take, okay? And there's a saying that if there was a drug that was as beneficial, as effective as exercise, doctors would be prescribing it all the time. But you know what? Unfortunately, exercising is not like taking a pill. It requires time, it requires motivation, it requires bravery, it requires commitment. And there is no magic pill, but exercise is really, really effective for everybody, okay? As I said, move more and sit less. That should be your basic principle, because sitting is not good. And the question I want to answer for you is, does that apply for MS too? And very definitely yes, and quite a different way of thinking. So why do we think now differently about exercise than we did 25 years ago? So in the 1950s and 1960s, MS was actually diagnosed by a hot bath test. So you would put somebody into a really hot bath, and if it made their symptoms worse, they were diagnosed with MS, okay? And there's this relationship between heat and heat sensitivity, which is called Uthoff syndrome, that led to us thinking that exercise was harmful, right? So if we exercise, we get warm, right? And many of you may have experienced the really frightening phenomenon that when you exercise and you work hard, your fingers get numb, or your foot starts to drop, or your eye goes blurry, and that's really, really scary. But what I need you to know is that that is transient, okay? It's because you're warm, and as soon as your body temperature returns to normal, those excessive symptoms will reverse. But you can see how we used to think that exercise was bad, because people's symptoms would get worse when they exercised because they got hot, okay? So we now know that heat sensitivity, or as it's now closed, is transient. It will resolve. And the interesting thing, there's a research group in Denmark looking specifically at this, and they think actually it might improve as your fitness improves. So as you exercise more, the sensations may decrease. But it's really scary. You know, you think, okay, I'm going to beat this MS diagnosis. I'm going to go out and do some exercise like everybody says, and then suddenly your hands go numb. That can be really scary. But don't let it put you off, because it is transient, and that's the important message. And there's things that you can do to combat heat sensitivity. So if you're somebody who finds that you really can't tolerate heat and your symptoms get worse when you're hot, wearing this actually cooling vests that you get. Some people will make their t-shirts wet so that you feel cooler. Drinking cold water. Now, drinking cold water is an interesting one, because if your bladder is sensitive, drinking cold water is going to make your bladder more sensitive. So that works for some people, but not for others. Exercise in cold environments, that's kind of a no-brainer. But if you like to go to the gym, find the treadmill that's under the air conditioning vent, or find the open window, or exercise outside, or exercise first thing in the morning or last thing at night. Think about the temperature. And also with heat sensitivity, if you have something that has breaks, so instead of exercising continuously for half an hour, you might want to do 5 minutes of exercise, have a 2-minute cooling break, do another 5 minutes, have a 2-minute cooling break. So sometimes strength training suits people with heat sensitivity better, because you naturally take breaks between stations or between circuits. And if you do want to exercise aerobic, you can divide it into shorter bouts. So what we know about aerobic exercise now is that, yes, 30 minutes is good, but actually you can accumulate very similar benefits if you do 3 10-minute bouts. So you don't have to go and exercise for a long period of time. You can break it up into small chunks, do a little bit now, a little bit at lunchtime, a little bit later. Okay? So that's heat sensitivity, and I think it's really important to acknowledge it up front, because that's really the reason why we used to think that exercise was harmful. We now know that it's transient. Okay? So I'm going to answer some questions with research, and I just want to walk you through this. I'm hoping that you can see the mouse on the screen. You can't? Okay. So ladies, it's all about the diamond, okay? So that diamond is what we're focusing on, all right? And you can see there's a line the blue arrow is pointing to. That's the 0 line. So if there was no effect, the diamond would be sitting on the fence. It could go either way, okay? So what this is doing, it's taking all of the research studies that have been published that look at aerobic fitness, it's putting them all together, and it's making a judgment based on a bigger data set, which is more robust. And you can see there's some variability. Some studies didn't do so well, some studies did very well. But the diamond is sitting clearly off the fence, and the diamond is sitting clearly to the right. So there's a positive effect of exercise on fitness for people with MS. So people with MS can get fitter, basically. And that's cardiovascular fitness, your heart and lungs getting fitter. The next bit is strength fitness. The first one was muscular fitness. This is cardiovascular fitness. And again, it's a definitive yes. The diamond is clearly off the fence. It's on the positive side. So we can see that exercise is beneficial for both improving strength and improving how your heart and lungs respond to exercise. Okay, so that's good. We can change, and people with MS can improve their fitness. We talked about fatigue earlier as being one of the really most common symptoms. I think up to 85% of people talk about fatigue. And for those of you in the audience who don't have MS, this is not feeling tired. This is nothing like that. Some people will describe it as that achy, just have to lie down, fluey kind of feeling. It's not just feeling tired after a night out. It's a very different sensation. And I think probably the last thing that somebody who's very fatigued wants to do is exercise, because fundamentally you're feeling exhausted. So it's counterintuitive, but you know something? It has a really, really profound effect on fatigue. I had a young woman who did a program with me. She was so tired that she was going to bed every night at 8 o'clock. She thought she might have to give up work. She did a 10-week program with me, and at the end of it, she was running with her dog, and she was feeling amazing. So it does work. So exercise can reduce fatigue. And here's the research evidence beside it. Now, it's a big slide, because there's actually a ton of studies that have looked at the effect of exercise on fatigue. And this time the diamonds to the left become, we want fatigue to reduce. So we can see that overall, all of the exercise studies say that exercise can reduce fatigue. So if fatigue is your symptom, it's not intuitive to get up and exercise, but it's really important and it can make a difference, okay? And really interesting is that you want to think about endurance training, right? So strength training is not so good as for fatigue as endurance training. And by endurance training, I mean going further, going faster, going longer, okay? So you're kind of trying to extend the amount of time that you're exercising, okay? And that might have a more positive effect on fatigue than, let's say, strength training. One of the other symptoms that people with MS present with is depression, low mood. It's a hard time to get your head around a diagnosis. You're trying to live your life as well. But we've had a big change in thinking about exercise and mental health for everybody, and the same is true for people with MS. This is a meta-analysis that our group in UL did, and you can see again that exercise has a very positive effect on mental health. And you can see that, right? Getting up and getting out and achieving something is really, really important for everybody, okay? So the interesting thing about mental health is that we probably have to do it a little bit more often. So probably once a week isn't going to be good enough for mental health. We probably need to be thinking about 3 times a week, okay? So more frequently. And the interesting thing about improving mental health is that the exercise studies that improved fatigue had a bigger effect on mental health. So there's something about fatigue and mental health going together, which makes a lot of sense symptoms-wise for MS. Another common symptom is balance. Can exercise improve balance? And again, you can see the diamond is off the fence. It's clearly to the right. Balance is improving in general. But I just want you to look, because I think the type of exercise we do might be important for balance. So this is strengthening exercise, and you can see the diamonds on the fence. We're not sure that exercise can improve balance, that resistance exercise, I should say, can improve balance, okay? And what seems to have the biggest effect is walking, balance, and functional training. So you see the 4th diamond down. I was busily moving the mouse on the screen, forgetting you couldn't see it. So the 4th diamond down is the furthest away from the line, right? And that's walking, balance, and function and training. So if your balance is impaired, if you have trouble with your balance, you probably want to do something that challenges your balance. So sitting on a leg press machine is not going to improve your balance, okay? You need to be challenging your balance in order to improve your balance. And that makes sense, right? So, you know, if you want to get better at golf, you don't practice tennis, yeah? Kind of an extreme, but it makes sense for exercise. If you want to get better at balancing, you need to do something that works on your balance, okay? So all of this research evidence, and that's just a snapshot of the many, many hundreds of studies that are out there, has led to the development of the exercise guideline. And I would stress that this is the minimum amount that you should be doing, okay? So you can most definitely do more than that. So how often you should be exercising: twice weekly aerobic, and importantly, twice weekly of strength training. And I think for me personally, the aerobic is easy to get. I can walk the dog in the forest, and that's easy. The strength training is harder to find because I have to go somewhere or find a program or buy some equipment to do the strength training. But don't forget that you need strength training. And for women as we age, it's really important that we think about strength training. And men, but more importantly women. And the how much, and the really important word here is gradually. Gradually increase till you're doing about 30 minutes a session. I'm going to give you some strategies of where to start and how to get going in a second. But you want to be doing 30 minutes in a session, or you want to be doing 10 to 15 repetitions of exercise. And with the strengthening exercise, unfortunately, if it's not difficult, it's probably not going to be most effective. Now, come back to the beginning. Moving is good, right? So doing some strength training exercise is better than sitting on the couch. But for strength training exercise to be effective, it needs to be difficult. So about the kind of the 12th, 15th one is actually really, really hard, and you probably can't do any more. And that gets really beneficial strength training. How hard? Moderate intensity. And people always ask me, well, what is moderate intensity? So you can talk, but you can't sing. If you can carry on a conversation as usual, it's not moderate intensity. You need to be a little bit out of breath. And it's roughly 100 steps per minute. So I have my Fitbit on. And so if you're walking for half an hour, you should be doing at least 3,000 steps, and that would be moderate intensity, okay? 100 steps per minute. And what can you do? I'm going to change this and say you can do anything. I'm going to talk about that in a second. And this is another form of research which is called qualitative research, which is where we interview with people who've taken part. And it's really hard to read. All I want you to know is that there are more positives than negatives. So the stuff above the line is all positives. But people with MS talk very passionately about how it's helped them to be fitter, to have reduced fatigue, to improve their balance, improve their walking. And there's some people who have issues with it, but really the benefits outweigh the negatives, and that's what I want you to take from this. Now, can I just have a little disclaimer here? I've never done a 10K, fair dues to you, well done. I don't intend running a marathon, right? But what I want you to hear with this slide is that anything's possible. This amazing young man is Conor Devine. Conor lives with MS. He had quite a lot of disability because of MS. He has run marathons. He's now an Ironman, okay? I'm not suggesting that you're all going to be Ironmen. I'm not suggesting that you all have to run marathons. But what I want you to hear is that anything is possible, all right? There's nothing you can't do because of your MS. This is another lady, Anne-Marie McDade. She is a rower. She rowed in the Paralympic Games. She lives with MS. Some of you may know Emma Rogan, who runs the MS meetup in Dublin. Emma ran a half marathon. I just think that's phenomenal. And all I want you to hear is that anything is possible, okay? It's not for everybody. Like I said, I have no intention of running a marathon, but anything is possible. And people always say to me, well, what can I do? And what I say is anything you want to do. You might need to do it a little bit differently than you did because of your diagnosis. So maybe if your balance is a bit off, you might need to look for some supports while you're exercising. If you're very fatigued, you might need to cut down and then gradually build up again. But there's nothing that you can't do. I had a young girl once say, can I ride my horse? And I said, of course you can. If you enjoy it, if you want to do it, that's half the battle, okay? So these are some of the exercise types that have been shown to be beneficial. But basically, do whatever you want, because the most important thing about keeping up a good exercise habit is that you enjoy it, right? So my colleagues in sports science say, you should go to the gym and work out. It's like, no, I'm going to walk my dog in the forest, because that's what I enjoy. So find what you enjoy. The other trick is to find something that's convenient. If you think you're going to swim, and swimming is wonderful, but the pool is like over there and you work here and you live there, it's just not going to happen. So it has to be easy. It has to be something that you can walk out your front door and go for a walk. That's the easiest things. We all have feet, we all have shoes, we have a footpath, go walking. There's nothing to stop you. But find something that's easy to access. And the other thing to think about is if you have a particularly bothersome symptom, so maybe, for example, balance is your issue, you might want to think about Pilates or yoga or something that challenges balance. If fatigue is your issue, you might want to think about something aerobic, so that gets you out of breath, that you're going further. So just think about matching it with something that you want to improve with a goal, okay? How'd you get started? Just do it. Just do it. There's nothing stopping you. Just do it. And that's very easy for me to say. But one of the things that really helps is to start small and gradually build up. So what I wanted to share with you is the protocol for the Step It Up study, where we took 94 people with MS, who were completely inactive. They hadn't exercised since their diagnosis. And our aim was to get them to the exercise guideline, and more importantly, to keep them exercising after the study. So this wasn't just about bringing people in, doing exercises. This was about giving people the skills to keep going without us, okay? So that group started with 10 minutes of walking twice a week, and that's relatively little. But you know what? It's a good place to start if you're currently inactive, all right? And you listen to your body, and you learn what that feels like. And if it feels good, then try 15 minutes the next week. And if that feels good, then try 20 minutes the next week. And in 5 weeks, you'll be at the exercise guideline, which is 30 minutes twice a week, okay? But start small, gradually build up. Don't be tempted to go out tomorrow and suddenly go for a 45-minute walk if you haven't exercised in a long time, because you know what? You're going to feel crap. And if you feel crap after exercising, it's not going to make you want to go back and do it again, is it? So start small, gradually build up. And in terms of strengthening exercises, they started with 12 of each exercise once a week, and then they built it up to twice a week, and then they built up to 24 twice a week, and so on, and then we started increasing the strength. And the effects are really, really beneficial. So getting people from being inactive to the MS guideline, reduce their fatigue by about 20%. It improves their walking ability by about 15%. It improved their mental health. It improved their balance. It had multiple effects. So being active is really, really good. It's good for your body, but it's also good for your soul. So you've taken that step, you've got started, you've had that Nike moment, you've got started. So now how do you keep going? And I could be talking to anybody. This is not necessarily a message specifically for people with MS. This is a message for everybody, for your significant others, for your parents, for your friends, okay? How do we sustain an activity? And it kind of touches a little bit on what Sinead was saying, is make a goal. What do you want to do? What do you want to achieve by exercising? But actually make two goals. So one, I want to feel less tired. I want to be able to do a full supermarket shop for 45 minutes without being exhausted. I want to be able to carry 5 bags of shopping up and down the stairs 4 times because you live on the 2nd floor. Whatever it is, yeah? But then you need to set a goal for how you're going to achieve it. So maybe your goal would be for this week would to be just do 2 10-minute walks. Maybe your goal for next week is to do 2 20-minute walks, whatever it is, okay? And the wonderful young woman who had such an amazing response to our exercise program, she actually put stars on her fridge. She gave herself a star every time she did it. It's really important to write down what you're doing, and I really like that exercise. Write down the fact that you've exercised. Tick it off. It's something you've achieved, and it's a big deal to achieve it. And I think sometimes we beat ourselves up about not doing things, but we don't celebrate the success when we do. So if you do manage to exercise each week, and you do manage to exercise for 2 30-minute periods each week, then celebrate that success and write it somewhere. Have an exercise log. Maybe use the other end of the notebook that Sinead gave you to do your exercise log. How much activity did you do? What did you achieve? Logging your exercise is a really important strategy. Look at others around you and what they're able to achieve. And maybe you don't have friends who have MS, but certainly there's a lot of people with MS on social media who are finding benefits from exercise, who are meeting the minimum guideline, who are doing amazing things, I had a young woman in my physio practice recently who is, I'm going to forget, CrossFit. She's a CrossFit champion or something. Amazing. So you do whatever you want to do, but get inspiration from other people around you. Learn from other people who have MS and who are living with MS. And a really, really important thing, write down what the barriers are, because there's lots of them, and it would be kind of foolish to think that there aren't any barriers. So write down the barriers, but most importantly, write down what you're going to do to address them. Yeah, because if the barriers are just sitting there in front of you and you do nothing about it, you're not going to be able to get going. But if you say, okay, right, so temperature is a barrier. Okay, so I'm going to exercise first thing in the morning, last thing at night. Yeah. Or fatigue is a barrier. Do you know what? Fatigue is a barrier, but if I exercise and become fitter, probably my fatigue will decrease, okay? So acknowledge them, hit them head on, but more importantly, have them. And do you know what? The most important thing, I'm giving you permission to not exercise. When you're feeling crap and you don't want to do exercise, that's fine. I'm giving you permission not to exercise. In fact, I'm telling you not to exercise. And I'm also telling you not to beat yourself up about it. Because you will all have bad days. You will have days when your fatigue is bad. You'll have a bad day at work. You'll have all of these things. And it's really important just to say, bad day, I'm giving myself a break. And it's okay to do that. The most important thing is that you have a strategy to get back again. And you don't just keep having bad days, okay? Because you will find benefits from being active. Maria talked about the lifestyle management of MS. It's becoming much, much more to the fore. And we know that people who are physically active have less relapses than people who don't. So if we look at all of those research studies and we look at the people who didn't exercise compared to the people who exercised, the people who didn't exercise have more relapses. So being physically active is part of your MS management strategy, okay? It's part of all of the different things that you're going to do, sleeping right, being on disease-modifying medications, being physically active. It's all part of that big puzzle of reducing your MS symptoms. So as I said, I'm giving you permission not to exercise when you're having a bad day, okay? So, some considerations, because living with MS is not easy, and you're going to fluctuate from day to day, and most importantly, you're all going to be different, okay? So, listen to your body on that day. As I said, are you very fatigued? Are you feeling good? And do what's right for that day. So even if you just get off the couch and do 10 minutes, that's better than sitting on the couch, okay? And you know what? Probably when you get up, you'll start to think, okay, actually I feel good and I can keep going, all right? If you are on injectables, generally we advise you to avoid strengthening hard for muscle groups just after you've injected. So let's say you inject it into your quadriceps muscle, into your thigh. You might not want to do lots of squats or lots of lunges or lots of step-ups on the next day. Give that muscle a chance to rest. Heat sensitivity I've talked about again. Some people love the heat. Most people I've met with MS hate the heat. So just think about how you're going to manage that. Take a water bottle, fill it half with water, freeze it, and then top it up with cold water. Hold that against your wrists, hold that against your body, drink from it. That's a nice way of getting your core temperature cold. And as I said, there's things like heating vests and other strategies. And the biggest consideration is this kind of boom and bust thing. And remember I was saying I don't want you to go out and do 45 minutes exercise tomorrow if you haven't done anything for a long time, because you're going to feel crap. So you don't want to have this cycle of too much, nothing. Too much, nothing. Start small, gradually increase, slowly but surely increase up to at least the exercise guideline, and further if you choose, okay? And that's it. That is my advice for you. So the minimum exercise guideline is 30 minutes twice a week of aerobic exercise, or something that gets your, so you can talk but not sing, 100 steps per minute, that gets your heart and lungs going, and 2 strength training sessions a week. That's what the minimum exercise guideline recommends. And if you meet that guideline, we know that you can have significant reductions in fatigue, significant improvements in mental health, improvements in your balance and in your walking, and many, many other MS symptoms, okay? So hopefully that information is of use to you, and thank you very much.
That's a fabulous talk, thank you. That was great. So if you have your question cards, we're just going to collect them here, if you want to pass them over. If you have any questions, don't be shy. So I hope you all enjoyed that anyway. There was so much information today. It's such a nice day, fabulous speakers. Thank you to all the speakers, if you want to give a round of applause. Fantastic information. You can also watch back if there was any points you didn't get down or anything like that. You can look on the Facebook page, the MS Facebook page, and you can have a look through the slides again. We're going to pause it now for 10 minutes after the questions, so we're going to read out some questions, and then we're going to take a little 10-minute break, and you can get your water, go to the bathroom, because then you're going to do a little HIIT class, high intensity fitness class, with fearless moves are going to come in. So we'll all get moving, and then after that you'll be very hungry and you can eat. Alright, hope you all enjoyed it, and the questions, will Aoife be doing? Ah, there she is.
So question 1 is for Sarah. Sarah, how do I access services like a sexual therapist?
So Maria and I were talking actually before the session started, and she will often refer people to the NRH. There is a specialist there who looks at sexual function for a wide variety of people with different life experiences. I know particularly down there at the spinal unit. So you can do that. You can Google. There is a sexologist in Ireland at the moment called Emily Power. She practices in Dublin. I know she has rooms in Dundrum. There is me. You can contact me through Instagram at the moment because my website is down. Does that answer? But I guess the thing is, I did say in my presentation that if you go to a neurologist, you can be referred. But let's be clear that not every neurologist or not every urologist or every gynecologist will have sort of a deep understanding of sexuality and how important it can be for different people. So oftentimes, if you've made that really
difficult first step of asking for help, and you don't get to the right person. It can be really like body sort of still on, disheartening. And I would encourage you to, you can actually reach out to me on Instagram and I'll give you some encouragement. I also provide an advocacy service, so if you're finding you're not getting to speak to the right professional you need to speak to, certainly contact me. I have in the past advocated for my clients if they're not getting the response they need from their healthcare professional. Does that answer the question? Everyone happy with that? Yeah. Great.
Next question it's for Maria, and is there any research being done in Ireland into the relationship between MS and CCSVI?
Not at the moment as far as I'm aware, because the therapy is largely been unproven in many of the clinical trials. This was a procedure, for those who aren't aware, I suppose it was advocated particularly by an Italian clinician about 10-15 years ago, maybe a little bit more than that, and it involved a procedure to open up the veins in the back of the head, and it was felt that this might provide beneficial for MS patients, but there have been no well-performed clinical trials showing that this procedure has any benefit. And I think it had a particular vogue during a period of time when there was very little other therapies available, and I think people went for this procedure really because they didn't have many other options open to them. And now there are a lot of other evidence-based good treatment options that we would strongly encourage, rather than spending money doing an unproven procedure privately, and it's not something that's being pursued, because I think the feeling internationally is that there's no evidence for this being beneficial.
Thank you. And the next question is for Sinead, and the question is, I'm not currently working. How do I protect myself from being excluded from consideration for being hired if I decide to be open about having MS?
That's a really good question. I think to focus on the cognitive diversity piece, what you bring to the table. So rather than focusing on what you don't necessarily bring to the table, focus on what you do. And I just noticed somebody's t-shirt and it had brave and friend, and I don't know exactly what's written on it, but yeah. You come to the table and you talk about your ands rather than the ors. So, I am good at this and good at that. Use the VIA.org to help you for the language around that. It gives you the language that you need to enter into that space. And do your Thursday, genuinely. Pick out the things that you are achieving. Use an achievement list every week. What did you learn that week? What did you knowledge base that you build, and what skill that you build, and then consider how that transfers into the workplace. If somebody is discriminatory against you, I do suggest that you use your voice and speak. It's not the easiest thing to do, but I do think that that type of behaviour has to be called out, and people that choose to display that behaviour need to be called out on it. But certainly use edX, use FutureLearn as a way to show that you're upskilling, reskilling. It's something that you can start a conversation with, and then use your Thursdays with your achievement list, what you've been doing, whether it is work related or not, and how that's a transferable skill that you can use in the workplace. I hope that answers the question. If there is something else on it and I haven't adequately answered, let me know.
So the next question again is for Maria, and the question is, can you revert to a first-line treatment for the purpose of pregnancy if you are already on a second-line treatment?
It's a great question. The answer is yes. In relation to pregnancy, a lot of people here will probably be on an oral therapy, like for example Tecfidera or fingolimod, or even one of the higher efficacy therapies like Tysabri, alemtuzumab, Mavenclad, or rituximab. So say for example you're planning pregnancy, your MS has been a little bit active in the past, but you have been stable on your current medication for the last couple of years. You could have that discussion with your neurologist. So your options are discontinuing the Tecfidera or Gilenya entirely, waiting 2 months and trying to conceive, or as you're discontinuing your oral medication, starting on a medication like Copaxone, Avonex, Rebif, one of the interferon medications, and continuing that medication up until the time of conception. And I think for a lot of people that is certainly an option they might want to consider, particularly if there's any reason that it might take you a little bit longer than expected to conceive. And I think that's something that sometimes we don't all take into account. That you're like, okay, wait 2 months and then conceive, as if it's going to be like, baby here, fantastic. But it can take people 3, 6, 9 months, up to a year to conceive. I think if things aren't happening very quickly, another thing I'd suggest is go early for fertility testing. There's no point in spending a lot of time off a disease-modifying medication and trying to conceive if it's something that's going to be challenging for you anyway. So explore all these areas, yes, early. But yes, that is a definite option that you can take.
So the next one is for Susan. So the question is, I'm not currently working out. How can I sustainably start exercising? And can I find a program online?
Ooh, good question about the program online. Intermittently we run a program called Activity Matters through MS Ireland. It's not open right now. We will probably open it in the new year, and that's a web-based program. If I was directing you to online resources for exercise, I would suggest the MS Trust or the UK MS Society or the National MS Society in the US. And the reason being that there's an awful lot of stuff out there that is not validated and I guess scientifically proven, and you're better to go with the big organisations like that who have lots of information. But that said, I mean, as I said, walking is it's the easiest exercise to do because you don't need any equipment and you can do it anywhere once you have a pair of shoes on your feet. So if I was telling somebody to get started, I would say find something that's easy to do. If there's something you used to like doing exercise-wise, try restarting that, but maybe start with doing about 50% of what you were doing and then gradually build up rather than trying to go straight back to doing exercising at the level you were beforehand. But yeah, I think find something that you enjoy doing is my biggest advice. You don't have to work out in the gym. I don't work out in the gym. You need to find an activity that you enjoy because that's the one that you're most likely to keep going with and keep going. So it could be going to a Pilates class in your local community. It could be going to the local gym and doing CrossFit. It could be going for a walk with the dog. It could be anything. So just find something you enjoy.
The next question is for Sarah again, and the question is, how do I bring up issues regarding my sexuality with my healthcare professional?
Oh, excellent. That's a great question. Okay, well, you do need to be brave because most of us are conditioned to believe that we're not meant to have these conversations. But oftentimes when we want to have a conversation that feels like it's going to be scary, it's useful to prepare the other person ahead of time. So, for example, you could say something like, now I need to talk about something that most people find embarrassing, but this is really important to me, right? So you're giving them warning that you're going to be talking about something that's slightly out of the ordinary, but you're also saying this is super important to me, so please don't brush me off. Because our healthcare professionals, they're humans, and the rules that I was telling you about that we have in our heads, our healthcare professionals have those in their heads too. So by saying to them, most people feel awkward about this, but this is really important to me, you give them an opportunity to say, okay, well, prepare themselves for what is this going to be? And as a general rule, they'll know anyway as soon as you say that. So that's one idea. Another way to do it is the other way to start a conversation is to say, I learned something the other day and I'd like your advice on it, or I'd like to find out get your input on it. So it's not a sort of a personal thing you're talking about. You're more saying, I read this blog post and it was about masturbation and I'm just not really sure about my situation with masturbation. And so it's more external. So you feel more comfortable and they may feel more comfortable.
Great, thank you. So unfortunately we just have time for one more question. So the question is for Sinead, and the question is, should I disclose my MS in an interview?
That's very personal. There's no need to disclose it in an interview if you choose not to. So that is up to you. It is a personal decision. So if you choose to disclose it and you want to disclose it, but don't feel the weight of having to disclose it. It is up to you completely. And if it's not something you want to disclose, you don't disclose. If it's something it's very important for you to disclose it. That is entirely up to you. I know that doesn't tell you what to do, but it does say that it is your choice. And it is not something that, based on the disclosure of that, it is not okay for you not to get the job. So based on the disclosure of the fact that you're living with MS, and if you don't get the job, that cannot be the reason for you not getting the job. So it is very much up to you. I don't know if anybody else has an opinion on that, but I mean, I'm coming at this from a kind of a career psychology perspective rather than from a HR or a legal perspective. But I would say to you, it is illegal to discriminate, and it is up to you. There is no onus on you to disclose. Absolutely no onus. It is a personal choice.
Thank you. So just to let you all know that we're going to take a 5-minute comfort break. So there's water at the back of the room here if anybody would like to come get some. And then after that we are going to do a lovely gentle exercise session that you can all do in whatever clothes you want. So don't be worried if you're not in the most comfortable gear for it. So we'll be doing that for 20 minutes, and then after that we're going to have lunch. So we're going to take just a 5-minute comfort break now. Thanks.